I started playing soccer when I was about 5 years old, and I've played every year since then.
I've been playing since I was around 5. I first started just doing like a little club thing with one of my friends, and then other than that, I've just been playing AYSO every single year.
I tore my left ACL when I was at a club soccer practice. This was on a turf field, and I was running super fast, and after I kicked the ball, I landed on my foot weird, and then I tweaked my knee and I tore my ACL.
30 seconds into the game, I got like a head ball to the face, like straight smack. It hit me to the floor and I was like, oh, I'm fine, like go get up. Not, but like a minute later, I got another ball to the face. That was what I should have known, is to just get out and like take a rest, but I didn't. And then I want to say like 2 minutes later, I got a ball passed to me. I was really confident that I could just straight take it out. But then I just stepped completely wrong, and that's when it snapped. And it was very, very loud. Everyone heard it. Someone thought there was like a bone collision, but there was no girl around me that there would have been a bone collision with. So they're like, oh, what the heck? And I was like on the floor.
About 8 or 9 months after I started playing again, I got my second injury. I was just running, and as I switched my direction, my knee just moved weird, and I tore my ACL. I was completely shocked, because I know that the recovery time for that kind of injury is very long, and being away from soccer for so long is just super scary for me, because soccer's my life.
We developed the Youth Injury Prevention Program in partnership with AYSO because a lot of these injuries can be prevented. And specifically in soccer, specifically ACL injuries, have really good programs. So we found that if we can reach them earlier and help prevent these injuries, we could have a bigger impact on their lives as opposed to just treating them down the line when they're already injured.
Youth sports medicine at the Institute here is really the core of what we're most focused upon. Yes, we take care of the professional, the elite athletes, but the youth athlete is really the core beginning of what we need to focus on.
This is a global issue beyond the youth landscape in America. If you look at the situation with this previous Women's World Cup, one I looked at England and I looked at USA, both favoured to win. England lost 3 players, Leah Williamson, Fran Kirby and Beth Mead, to ACLs. USA lost Kristen Press, Mallory Swanson and Katerina Macario. That's 6 world-class players on 2 teams that were unavailable through ACLs or serious knee injuries. So there has to be a change, a paradigm shift in how we're looking at this whole concept and draw attention to it.
Besides serving on the National Board of Directors of AYSO, I've coached in AYSO for 18 years. I know from my early coaching experience that we did not place enough emphasis on training our coaches about injury prevention. So for me, this is personal. You know, the first time you have to walk out on a pitch and a kid you care about is laying there in pain, and you know that it's not only that pain that they're going to suffer, but it's the emotional pain of having to leave the sport they love for a while, maybe forever, having to leave their teammates, go through all that recovery. Well, it should be personal for every coach.
When it comes to prevention, I think there's so much more we can do. We now understand and have evidence that supports implementing athletic training programs, biomechanics training programs that can really make a difference to prevent these injuries. And now our biggest hurdle is implementing these programs so that kids actually get exposed to them, have the developmental changes, and prevent the injuries.
ACL prevention program should start extremely young, 7, 8, 9, 10, teaching young girls how to land, how to jump, how to avoid injuries, just to understand that that's important.
If you incorporate injury prevention early, then it's going to be part of the sport, just like wearing shin guards and cleats. And then when it actually matters, it won't be something you have to add on to them later on.
AYSO's vision is we can prevent this from happening in the first place. And if we can do that, that's where the emphasis needs to be.
If we believe in enriching children's lives, we have to prioritize their wellness and health and treat the child in addition to the athlete. To really create a holistic environment for a child's development is the key. And holistic would involve health, wellness, and prevention in addition to technical and tactical.
I think the big thing to remember is these injuries are preventable, and we have the ability to prevent them. So by implementing these programs, we can truly make a difference. Hello, my name is Dr. Tracy Zaslow. I'm the Medical Director of Pediatric Sports Medicine at Cedars Sinai. I'm also the team physician for the Angel City Football Club, the LA Galaxy, and a consultant with the Los Angeles Ballet Company. Today we're going to cover the topic of ACL injuries in the female athlete. To start, I have no disclosures. First, let's review a few soccer stats. There are over 300 million soccer players that participate globally. Soccer is the third most popular sport in the US with 13 million participants. And when we look at high school soccer and how it breaks down by gender, it skews a little bit more male than female, but is pretty close to about a 50% spread. When we get to the professional level, female representation drops to about 21.4%, but with the expansion of the Women's Professional Soccer League, that will likely change going forward. Taking a look at injury rates at the collegiate level compared to other sports, soccer, unfortunately, ranks number 1 for women's sports. When you look at men's sports, football, wrestling, and soccer do beat out women's soccer for injury rate, but women's soccer has the highest injury rate for any women's sport. That's a stat we'd really like to change. Looking at the musculoskeletal injury rates and comparing the differences between genders, what we see are females tend to see more joint injuries, especially injuries at the ankles and knees. For males, thigh injuries are more common, involving muscle strains of the hamstrings and quadriceps. We also see different injury rates from different levels and leagues. In professional basketball, WNBA players have a higher injury rate than their male counterparts in the NBA. Similar stats are present in the high school population. Interestingly, in the collegiate athletes, males do have a little bit more injury than their female counterparts, but that may just be due to the higher number of athletes that participate. When we look specifically at ACL injuries in high school sports, again, girls soccer is number 1. They have the highest incidence rate per athletic exposure. That means that for every time female athletes are on the field, they are more than twice as likely to tear their ACL compared to their male counterparts. Other sports with high ACL injury rates are boys football, girls basketball, girls gymnastics, boys lacrosse, and girls lacrosse. Any sport that has cutting type maneuvers is at high risk, but girls soccer, unfortunately, takes the prize. This picture shows one of the previous US women's national teams. All of those who have circles around their head have had at least one previous ACL reconstruction, and many have had multiple reconstructions. For this team, 45.5% of the starting 11 have had at least one or more ACL reconstructions. Today we'll be covering some background on the ACL. We'll talk about what the ACL is and how it is injured. I'll go through the treatment protocols, and our big focus will be how we prevent these injuries. There's a lot we can do as parents, as coaches, and as players, so we'll emphasize that today. I'm sure everyone has heard the term ACL thrown around before, but what is the ACL? ACL stands for anterior cruciate ligament. The ACL is a ligament that connects the femur, the thigh bone, to the tibia or shin bone. The ACL is a really important ligament for stability in the knee. It prevents the knee from shifting front to back, and it also limits rotation. When the ACL is torn, the knee is unstable, making it difficult to change directions or change speed with control. And this instability can lead to further injury to the cartilage of the knee. So, what age groups are most at risk for ACL injury? This graph demonstrates that 15 to 19-year-old girls demonstrate the highest risk. Boys' rate of injury is a little lower, but lasts from 15 to 30 plus years old. It may be in part because these age groups have higher participation in pivoting sports, but there are probably also biomechanics issues that come with growing and changing at that age. So it's definitely a population to target for injury prevention strategies. Also, depending on which study you look at, female athletes are 4 to 6 times at higher risk than their male counterparts for ACL injuries. Again, for high school athletes, we see ACL injury rates higher in girls soccer than boys, higher in girls basketball than boys basketball, and higher in softball than baseball. So lots of injuries for female athletes, which is why we're focusing on that today. Looking at the pediatric population, we used to believe young kids could not tear their ACL. Unfortunately, we were wrong. This diagram shows that the ACL annual injury rate has increased about 148% over a 10-year period from 2005 to 2015. In this study, looking specifically at the 5 to 14-year-old age range, 10 to 14-year-olds had the most injuries. While our 5 to 9-year-olds are much less likely to have an ACL tear, that risk increases significantly as they approach the 10 to 14-year-old range. So why are we seeing more ACL injuries in children over the past few decades? Number one is we have better awareness. Previous thinking was that kids wouldn't get ACL tears. The thought was that kids break bones but don't tear ligaments. Unfortunately, kids do tear the ACL, and now with better MRI imaging techniques and availability, we're able to diagnose it a lot more. Additionally, the number of children participating in organized sports has increased. That participation is a lot more intense. They're starting earlier, they're doing more practices per week, more hours per day, and with more intensity than previously. So, what do we do when the ACL is torn? There are two main options. You can have surgery or you can choose not to have surgery. So what are the statistics? If you don't have surgery, how will you feel in life? It's been shown that about 75% of people who don't have surgery will have a lax knee, which is a loose feeling knee. So they'll feel unstable when they're trying to cut or change directions in sports. They'll also be about 12 times more likely to have a meniscal tear. The meniscus is the cartilage that's in the knee. With the ACL torn, there will be more shearing motion between the tibia and femur. This breaks down the cartilage that sits between the bones, normally working to provide a cushion. Those are the risks of not having surgery. So for those who have surgery, how do? They can do quite well. When we look at the return to play for pro soccer players, about 72% of athletes can return to that level of play. But amongst your average athlete, it's much higher than that. So we know that surgery can be effective. When it comes to the surgery, we've had to go through a learning process to determine the best surgical procedure to fix the ACL. In the past, ACL repair was done where the surgeon would try to sew the two torn pieces back together. With that method, there was about a 50 to 90% failure rate, meaning that the ACL would tear again. Repair has kind of gone out the window and has been replaced by reconstruction. So what is ACL reconstruction? Reconstruction is when you use something else to replace the ligament. For reconstruction, the surgeon removes the old ACL that was torn. Then they take either a piece of the patellar tendon, quad or hamstring tendon, or even a tendon from the cadaver. Then they'll drill holes and run a new ligament through the spots where the ACL used to be attached. After a period of rehabilitation, the athlete will eventually get back to play. This method is great for adults, but it's a bigger challenge with kids. The reason it's a challenge is that kids have open growth plates. Growth plates are where your bones get longer as you grow. In this x-ray, you'll see these black lines. They represent where the growth plates are. These growth areas are very fragile. If we were to do a traditional adult technique where you drill through the bone, you would drill right through the growth plates, and that can cause the growth plate to stop growing. For kids, that's a big deal because you'll end up with one leg longer than the other, which is not the outcome we want from the procedure. There's been a number of techniques that have been tried to go around or spare the growth plate. In one technique, surgeons go outside of the growth plates. This is called extraphyseal. In another, called epiphyseal, surgeons go below or in between the growth plates. The sports medicine community is still exploring options for kids who have ACL tears but are still growing. There's been a lot of research recently into what can be done to make repair better. There's a procedure called the BEAR, Bridge Enhanced ACL Repair. In the BEAR procedure, a scaffolding of different factors is used that helps promote growth. What happens is that the ligament can fill in this gap and restore the normal ACL. Dr. Trent Acosta, one of the physicians in our group, has been one of the leaders in this research and has done many of the procedures. In this graph, we see failure rates in adolescents. The red column shows traditional repair, and you can see this has a high failure rate. The green columns represent studies looking at failure rates of reconstruction procedures. The BEAR studies, represented in the last two columns on the right, are very small, but so far it appears that the BEAR has shown some really promising outcomes. These data show a low re-tear rate with this procedure. It's still early, but we will follow future data to continue to improve operative care of the ACL injury. Let's take a step back and understand how the ACL gets injured in the first place. There are two main categories for ACL injury: contact and non-contact. Contact is when there's another player that physically causes trauma to the leg or the knee that strains the ACL and causes it to tear. Those are tough to prevent. But non-contact injuries are very preventable. So, how many injuries are non-contact? There was a great study that looked at this very in-depth and found about 88% of injuries are non-contact. That means that we have a big area of ACL injuries that we can prevent. Most of these injuries occur with deceleration or slowing down, cutting or changing directions, or landing. However, 44% of the 88% are indirect contact. This occurs in the face of being tackled. So they might not actually have any contact with the other player, but they're moving out of the way or changing their footing to avoid another player. And that's where an athlete is most at risk. So we really need to work on the biomechanics in that positioning. Now let's look at risk factors for ACL tears. What makes the ACL at risk for tear? There are a lot of factors, including anatomy, the structure of the bones and ligaments, genetics, environment, including the surface athletes are playing on, hormones, and much more. So first, let's talk a little bit about hormonal changes. Hormones fluctuate over time. When estrogen levels are higher, there can be a relative laxity or looseness to the ligament. That may predispose athletes to ligament injury depending on the timing of their cycle. Other risk factors include environmental differences. This refers to the surface of play, turf versus grass fields, and what the quality of that field is. Additionally, medical training resources play a role. Do athletes have coaches and trainers that can assess their movement patterns and implement prevention regimens? Every single ACL tear that happens likely has a different combination of all these factors, but the factor we're going to focus on primarily today is biomechanics. This is where there's a lot of research, a lot of evidence-based medicine, and this is where we can really work to prevent and make changes that make a difference for these athletes. Before we dive into the biomechanics, I want to talk about a few anatomical components that may increase risk. Females have been shown to have a little bit more laxity, meaning looseness of the ligaments, than males. Number 2 is females have less muscle strength and endurance. What that means is that the muscles around the knee are not as strong and they fatigue faster. That puts the ligament at risk because it won't have the support of the muscles. Lastly, females take longer to generate torque in the hamstring muscles in the back of the leg. You need the torque to stabilize the knee so that it doesn't shift forward with the movement. All of this can be worked on to make biomechanics optimal with every step or landing. On the right, you can see the incorrect landing pattern, where the knee comes across the center line, called knee valgus. Ideally, the knee comes forward over the toes and body weight is evenly distributed with the force coming straight down through the knee and foot. In this video, you'll see an athlete jumping. You can see that when she lands, her knees just collapse, virtually touching one another. This is not the biomechanics that we want, and this puts a lot of strain on the ACL. What we're looking for in a landing is that the knees are coming straight forward over the toes with no valgus or collapse. This is where we can target our prevention. So what can our athletes do to prevent these injuries? They can train to focus on specific muscle strength and movement patterns. This photo shows an athlete before and after implementing a prevention program. You can see on the left that her knee is collapsing and her hip is dropping. That puts all the forces right through the knee, stressing the ligament. Whereas on the right, the knee is going forward. She has a neutral pelvis and the hips are not dropping. This is what our goal is for all our athletes. There are several training programs that have been developed to prevent ACL injury, and a lot of studies have been done to look at the effectiveness of the different programs. All incorporate a lot of the same elements of biomechanics, training, muscle training, as well as movement patterns, and they show about a 60 to 89% success rate, depending on which program you choose. We'll be focusing on the FIFA 11 program because it's well studied and most specific to soccer players. They have 2 versions of the program. One is aimed at kids 7 to 13 years old, and one is for those 14 and older. The program has about 15 exercises that are performed ideally twice a week in practices. If performed twice a week, it's been shown to decrease injury rates by about 30 to 50%. A study looking at the younger population of 7 to 13-year-olds who did the program twice a week were able to decrease their injury rate by about 48%. Interestingly, another study came out which highlights a really important point. The study showed that implementing the FIFA 11 injury program in high school students didn't actually reduce their injury. But when you tease out the details, about 62% of coaches in this study reported that their teams did the program less than twice a week. Only 32% did it at least twice a week. This study helps us understand that if you don't do the program, it doesn't really work. So you really need to do the program multiple times a week for it to be effective. Here we have another set of studies examining compliance with injury rate. The blue bars in the graph show how often participants were doing the FIFA 11 program, with the tallest bar on the right representing those who did the program more than 40 times within the season, compared to the short bar on the left showing those who did the program only 1 to 19 times per season. The red line is the injury rate. You can see that those who did the program less than 20 times in the season had a much higher injury rate than those who had been very compliant and done it more than 40 times in the season. So the mantra of this program is just do it. FIFA 11 makes a difference when it's done. Additionally, not only does FIFA 11 prevent injury, studies show teams who do the program win more. This chart represents teams that did the FIFA 11 program, represented in red, compared to teams that did not do the FIFA 11 program, represented in blue. The results are impressive. Teams that did the FIFA 11 program won more games, which ultimately is everyone's goal. To sum it up, across multiple studies, FIFA 11 makes a difference, decreasing injury rates by about 53%. So this is definitely a positive for all our athletes. Now that you all understand the data, we want to use this data to motivate change. We have the information that doing the program twice a week can lower injury rate, improve a team's win-loss record, decrease time lost from play, and improve biomechanics overall. This will help our athletes maintain a healthy and active lifestyle. So far, we've talked about all the bad things that happen in soccer, how common ACL injuries are, and how we need to work to prevent them. So let's end our discussion on a positive note, reviewing some of the benefits of physical activity. Here's an infographic demonstrating how participating in physical activity is a real upward spiral. Studies have shown that children who are physically active are 1/10 less likely to be obese. These children have 40% higher test scores, are less likely to smoke, use drugs, become pregnant, and engage in risky sex behaviors. They are also 15% more likely to go to college, ultimately having 7 to 8% higher annual earnings and lower healthcare costs. They're more productive at work, have less healthcare problems as adults, and the intergenerational cycle continues with their children. Kids of active parents are 2 times more likely to be active themselves. These are all really positive outcomes of sports participation. Some other benefits of sports are in character development. Athletes that participate in sports build confidence and competence, which help them to become better leaders. They experience connection with teammates, other athletes, and adult leaders to improve their relationship and teamwork capabilities. All of this builds self-esteem, a quality that will help them through life. These skills translate off the field and will serve them well on other teams at work, school, and socially. Lastly, some female-specific stats. Female athletes that play sports in high school have a 92% less chance of using drugs, are 3 times more likely to graduate high school, are 80% less likely to get pregnant, and are 73% more likely to earn a college degree. So a few take-home points. Number 1, ACL injuries are too common. Prevention is the key to ACL injuries. So when it comes to prevention programs, just do it. And you, as the coaches, you're the ones who can take the lead to integrate these prevention programs. Lastly, the benefits of sports participation really do extend far beyond the field and are critical to developing the next generation. Thank you so much for your time and attention today.